Let's move on to lumbar puncture. Objectives. CLO number 1. Define the terms related to assisting in lumbar puncture. CLO number 2. Discuss the importance of lumbar puncture. CLO number 3. Examine the guidelines in assisting in lumbar puncture. CLO number 4. Discuss the indication and contraindications of lumbar puncture. Number 5. Describe the normal findings of cerebrospinal fluid. CLO number 6. Explain the complications of lumbar puncture. And CLO number 7. Identify the different sites in lumbar puncture. CLO number 8. Explain the principle involved in lumbar puncture. And lastly, CLO number 9. List the nursing responsibilities before, during, and after lumbar puncture.
Hello again. To start off our lecture in lumbar puncture, I will now define the terms related to assisting in lumbar puncture. Firstly, we have the lumbar tap. A lumbar tap or a lumbar puncture is also called a spinal tap. It is an invasive outpatient procedure used to remove a sample of cerebrospinal fluid from the subarachnoid space in the spine. Cerebrospinal fluid. The cerebrospinal fluid is a clear, colorless body of fluid found in the brain and spinal cord. It is produced by specialized ependymal cells in the choroid plexus of the ventricles of the brain and absorbed in arachnoid granulations. The choroid plexus. The choroid plexus is a plexus of cells that arises from the telechoroidea in each of the ventricles of the brain. The choroid plexus produces most of the cerebrospinal fluid of the central nervous system. The subarachnoid space. The subarachnoid space is the interval between the arachnoid membrane and the pia mater. It is occupied by delicate connective tissue trabeculae and intercommunicating channels containing cerebrospinal fluid. A yellogram is a diagnostic imaging test generally done by a radiologist. It uses a contrast dye and X-rays or computed tomography or CT scan to look for problems in the spinal canal. And lastly, we have the Queckensted's test. The Queckensted's test is a test for spinal blockage of the subarachnoid space in which manual pressure is applied to the jugular vein to elevate venous pressure, which indicates the absence of a block when there is a simultaneous increase in CSF pressure, and which also indicates the presence of a block when CSF pressure remains the same or almost the same. This is also called the Queckensted's sign.
So once again, I'm Stephen Plaza and I'll be discussing about the importance of lumbar puncture. So, the importance of lumbar puncture is enumerated. First, it is to obtain CSF for examination, to measure and reduce CSF pressure, to determine the presence or absence of blood in the CSF, and to administer medications intrathecally or into the spinal canal. Next, I will be discussing about the guidelines in assisting in lumbar puncture. So here are the guidelines in assisting in lumbar puncture. The needle is usually inserted into the subarachnoid space, the third and fourth, or fourth and fifth lumbar vertebrae. Because the spinal cord ends at the first lumbar vertebra, insertion of the needle below the level of the third lumbar vertebra prevents puncture of the spinal cord. Next, a successful lumbar puncture requires that the patient be relaxed. A patient who is anxious is tense, and this may increase the pressure reading. Third, instruct the patient to void before the procedure. Next, the patient should be positioned on one side at the edge of the bed or examining table with the back towards the physician. The thighs and legs are flexed as much as possible to increase the space between the spinous processes of the vertebrae for easier entry into the subarachnoid space. Another guideline is that the nurse should assist the patient to maintain the position to avoid sudden movement which can produce a traumatic bloody tap. A lumbar puncture may be risky in the presence of an intracranial mass lesion because Intraspinal pressure is decreased by removal of CSF, and the brain may herniate downward through the foramen magnum. Next, the specimen should be sent to the laboratory immediately because changes will take place and alter the result if the specimens are allowed to stand. And lastly, after the procedure, encourage fluid intake to reduce the risk of post-procedure headache.
CLO number 4. Discuss the indication and contraindications of lumbar puncture. First, it is used to diagnose central nervous system infections like meningitis and subarachnoid hemorrhage. Second, it is performed to relieve cerebrospinal fluid pressure. Third, it is used to confirm the diagnosis of idiopathic intracranial hypertension or pseudotumor cerebri. Other indications include the diagnosis of demyelinating or inflammatory CNS processes and carcinomatous or metastatic diseases. For the contraindications, it is contraindicated if there is an infected skin over the puncture site. Second, if there is trauma or mass to the lumbar vertebrae because this might lead to more trauma. Third, thrombocytopenia or other bleeding diathesis. And lastly, ongoing anticoagulant therapy because this can put the patient at risk for serious life-threatening bleeding. In CLO number 5, we will be describing the normal findings of the cerebrospinal fluid. So these are the normal values of the cerebrospinal fluid. It has a pressure of 70 to 180 millimeter of water. The appearance is clear and colorless. CSF total protein is 15 to 60 mg per 100 ml. Gamma globulin is 3% to 12% of the total protein. CSF glucose is 50 to 80 mg per 100 ml or greater than 2/3 of blood sugar level. CSF cell count is 0 to 5 white blood cells, all monoclear, and no red blood cells. And lastly, chloride is 110 to 125 milliequivalents per liter. So to give you a clear visualization of a cerebrospinal fluid, the first test tube is a normal CSF. So as you can see, it is clear and colorless. Then the second test tube is a centrochromic CSF, and it can be found in patients with subarachnoid hemorrhage, while the third test tube looks bright red or bloody, and this is a sign of bleeding or spinal cord obstruction.
These are possible lumbar puncture related complications: post-spinal puncture headache, bloody tap, dry tap, infection, hemorrhage, dysesthesia, and post-dural puncture cerebral herniation. Post-spinal puncture headache. It is the most common complication of lumbar puncture, observed in 20 to 70% of patients. It usually begins 24 to 48 hours after the procedure and is more common in young adults. The probable etiology is continued leakage of CSF from the puncture site. The headache is usually fronto-occipital and improves in the supine position, a bloody tap. More than 50% of lumbar punctures are falsely positive for RBCs in the CSF as a result of microtrauma caused by the spinal needle. This is an uncomplicated occurrence in healthy patients with normal coagulation system. However, if the patient has an abnormal coagulation system or have a problem with coagulation, it is more likely to have a bloody tap. Next, we have the dry tap. Dry taps usually result from misplacement of the spinal needle. The most common mistake is a lateral displacement, which can easily be corrected by withdrawing the needle completely and re-evaluating the patient's anatomy and reinserting the needle in the correct place and at the proper angle. However, in obese patients, the regular spinal needle might be too short, in which case a longer one should be used. If the patient is dehydrated, a falsely negative dry tap may be obtained as a result of very low CSF volume and pressure. If this is suspected, attempt to rehydrate the patient before the procedure. Next, we have an infection. Now, since the procedure is invasive, it is likely to put the patient in a higher risk of infection. Cellulitis, skin abscesses, epidural abscesses, spinal abscesses, or discitis can result from a contaminated spinal needle. However, adherence to sterile technique, including gloves, gowns, hair covers, and face masks, as well as thorough skin cleansing and disinfecting, should minimize the risk. Hemorrhage. Epidural, subdural, and subarachnoid hemorrhage are rare complications that might carry significant morbidity and mortality in coagulopathic patients. Lumbar puncture should be deferred or postponed in patients with low platelet counts or patients with other coagulopathies until the abnormality is corrected. Dysesthesia. Irritation of nerves or nerve roots by the spinal needle can cause different lower extremities dysesthesia. Withdrawing the needle without replacing the stylet can cause aspiration of a nerve or arachnoid tissue into the epidural space. To prevent this complication, always replace the stylet before moving the needle. And lastly, we have the postdural puncture cerebral herniation. A brain herniation or a cerebral herniation occurs when brain tissue, blood, and cerebrospinal fluid shifts from their normal position inside the skull or the spine. Cerebral herniation following the lumbar tap procedure is rare in individuals with no focal neurologic deficits and no evidence of increased intracranial pressure. If it occurs, it usually does so within 24 hours after the lumbar puncture. Thus, herniation should always be considered in the differential diagnosis if the patient's neurologic status deteriorates during that time frame.
Hello everyone, I would like to appreciate your efforts if you've reached this far in our video. Once again, I am Zarina Larante and I will be discussing CLO number 7, the different sites in lumbar puncture. A lumbar puncture or spinal tap is the insertion of a needle between the lamina of the vertebrae and into the thecal sac, with the purpose of obtaining cerebrospinal fluid. It is done below the L2 level, usually between L3 and 4 or L4 and L5, in order not to injure the spinal cord. I will be also discussing the CLO number 8, principles involved in lumbar puncture. First, anatomy and physiology. In performing lumbar puncture, the nurse must know the site of where to make a puncture. Failure to do so can lead to unnecessary complications. Microbiology. Microorganisms may complicate or worsen the condition of the patient. Maintaining the sterility of the equipment is a must in performing such procedure. Psychology. Before conducting the procedure, the nurse must explain the procedure and the purpose to the client to alleviate anxiety. Physics. This refers to the use of physics in conducting lumbar puncture. For example, using force in order to make a concise puncture. Safety and security. Safety of the client should be considered like, for example, proper execution of the procedure and proper handling of the syringe. And lastly, sociology. Building rapport with the client prior to the procedure is important in order to gain his or her trust.
I am Ms. Capilitan and I'll be discussing CLO number 9, which is to list down the nursing responsibilities before, during, and after lumbar puncture. Before the procedure, check the patient's chart for the doctor's order. You must make sure that this patient is being ordered to have lumbar puncture. Next is to ascertain if the consent form has been signed, so the client must have knowledge and must be aware that this procedure is being done. Next is to explain to the patient the purpose of lumbar puncture, how and where it's done, and who will perform the procedure, in order for the client to cooperate and to alleviate anxiety. Next is to promote comfort and instruct the patient to empty the bladder and bowel before the procedure, and establish a baseline assessment data, do vital signs monitoring and neurologic assessment of the legs by assessing the patient's movement, strength, and sensation. Place the patient in a lateral decubitus position. Assist the client to this position near the side of the bed with the neck, hips, and knees drawn up to the chest. An alternative position is to have the patient sit on the edge of the bed while leaning over a bedside table. Next is to instruct to remain still. To explain that he or she must lie very still throughout the procedure. Any unnecessary movement may cause traumatic injury. So during the procedure, place the patient's towel under the lumbar area. Perform skin preparation using betadine cleanser 3 times and then betadine paint 3 times in a circular fashion from inner to outer surface. Don sterile gloves. Then hand the other pair of sterile gloves to the physician. Arrange the materials inside a stock tray according to their use. Eye sheet, 3 cc syringe for anesthesia, spinal needle, 3 specimen bottles and gauze. And then loosen the lids of the specimen bottle and give the following to the physician. So with the dominant hand, give the sterile eye sheet and sterile syringe for anesthesia. And with the non-dominant hand, give the anesthesia solution. This hand is now unsterile, so place it on your back after serving the anesthesia. Using your sterile dominant hand, give the spinal needle to the physician. Once the physician is able to insert the needle into the subarachnoid space, he or she will remove the stylet from the spinal needle to withdraw CSF. Hand the specimen bottles individually and assist the physician in filling the 3 bottles. Give the sterile gauze to the physician, and while the physician removes the needle and applies pressure to the site, remove the eye sheath and secure the gauze with plaster, starting from the center to the sides, horizontally. So after the procedure, record the procedure in the client's chart with the date and time. Record the amount and character of the fluid, the pressure of the CSF measured, client's tolerance to the procedure, any changes in the client's general conditions, and any untoward reactions such as nausea, vomiting, and headache develop in the post-procedure period. Apply brief pressure to the puncture site. Pressure will be applied to avoid bleeding, and the site is covered with a small occlusive dressing or band-aid. Position the patient flat on the bed for 6 to 12 hours. Monitor vital signs, neurologic status, and intake and output. Take vital signs, measure intake and output, and assess neurologic status at least every 4 hours for 24 hours to allow further evaluation of the patient's condition. Monitor the puncture site for signs of CSF leakage and drainage of blood. Signs of CSF leakage include positional headaches, nausea and vomiting, neck stiffness, photophobia, sense of imbalance, tinnitus, and phonophobia. And then label the specimen bottles with the name of the patient, the room number, the date and time obtained, and the type of specimen. Ensure all samples are properly labeled and send the specimen to the laboratory immediately for further evaluations. And administer analgesia as ordered. Headaches after the procedure can last for a few hours or days and are usually treated with analgesics.